Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. Today's webinar is being recorded. If you have any objections, you may disconnect at this time. My name is Megan Walters, and I am a health policy analyst with the National Center for Health Statistics. I am pleased to introduce today's speaker, Dr. David Wong. Dr. Wong is the Chief of the Health Promotion and Statistics Branch at NCHS, which provides primary statistical and epidemiological support for the Department of Health and Human Services Healthy People Initiative. In this role, he is the Principal Statistical Advisor to HHS on national health goals established through the initiative every 10 years. An engineer by training, Dr. Wong's educational background includes a PhD in industrial engineering and a master's in science in health systems from the Georgia Institute of Technology, a master's in public health in quantitative methods from the Harvard T.H. Chan School of Public Health, and a bachelor's science in engineering in electrical engineering from Duke University. This webinar will describe the methods for measuring health disparities in the Healthy People Initiative and summarize their evolution over the past 4 decades. Our presenter will also share exciting insights into the latest tools and data visualizations supporting this initiative. The presentation will be followed by a question and answer session. Just a reminder, the audience is currently in a listen-only mode. Questions or comments may be entered through the Zoom Q&A box, and we will address them as time permits during the Q&A session following the presentation. And now I turn it over to our presenter, David.
Great. Thank you, Megan, for that kind introduction. It's an honor and a privilege to be with you all today. Next slide, please. This webinar is the first of 4 that are planned for the Healthy People Disparities webinar series. Today's webinar focuses on the evolution of health disparities assessment in the Healthy People Initiative. The next webinar, scheduled for 2023, will focus on measuring disparities in the current decade, Healthy People 2030. The final 2 webinars, as you can see, will review analysis and findings from the mid and end of decade disparities assessments of Healthy People 2030, the mid-course and final reviews, respectively. Next slide, please. This webinar includes a brief overview of the Healthy People Initiative. We will look at the history of health disparities in the initiative, including the evolution of the measurement of disparities and some disparities-related concepts. We will also cover examples of how disparities measurement has changed over the decades, focusing on the methods and data display in Healthy People products. While some of the product in these sections will be somewhat technical, the aim of this webinar is to provide an overview of health disparities assessment to a broad audience, including those with varying degrees of statistical expertise. So as I close with some takeaways, that will hopefully bring some of the material back to a level that is accessible to a general audience. I'm also looking forward to the Q&A session, which will follow my presentation. Next slide, please. First, I will give a quick overview of the Healthy People Initiative. Next slide. Healthy People was established in 1979 and provides a strategic framework for a national prevention agenda that communicates a vision for improving the health of all Americans and achieving health equity. At the heart of the initiative are the science-based measurable objectives with targets to be achieved by the end of each decade. And you can see here with the Healthy People logos over the decades that we are now in our 5th decade of the initiative. Tracking of data-driven outcomes is a key part of the initiative, enabling stakeholders to monitor progress and to motivate, guide, and focus action. And Healthy People offers a model for international, state, and local program planning. Next slide, please. Healthy People is a federally led and stakeholder-driven initiative with NCHS as a key partner. The Office of Disease Prevention and Health Promotion, or ODPHP, in the Office of the Assistant Secretary for Health, leads and manages the Healthy People Initiative in collaboration with a diverse group of stakeholders, partners, and organizations, including NCHS, the Federal Interagency Work Group, which is a steering committee for Healthy People, topic area work groups, which are composed of primarily departmental subject matter experts, the Secretary's Advisory Committee for 2030, which is an independent federal advisory committee of public health experts, and then there are also public and private organizations and the general public. Next slide, please. Part of the Centers for Disease Control and Prevention, or CDC, NCHS is the nation's principal health statistics agency and serves as the Department of Health and Human Services, or HHS, in an advisory role in the Healthy People Initiative. Since the inception of Healthy People, NCHS has provided statistical advice to ODPHP and to the topic area work groups, ranging from specific measurement issues for objectives and data sources to broader cross-cutting issues like overall health and disabilities. We have also tackled statistical approaches and methods, including work on health disparities, target setting, and progress toward targets. NCHS compiles all of the data for the Healthy People Initiative on a national level, as well as subnational data as time and resources allow. NCHS also plays a key role in analyzing and presenting the data, whether it's through formal publications, graphics and tables for the web, or content for public presentations and social media. And finally, we provide statistical expertise and technical assistance to users on various levels. Next slide, please. The National Opinion Research Center, also known as NORC or NORC at the University of Chicago, conducted a Healthy People user study in 2015. In response to a question about how Healthy People is used, NORC found that 82% of respondents used Healthy People to inform program planning to address health disparities. This was second only to using Healthy People as a data source. So clearly, data and disparities are key components of the Healthy People Initiative. Next slide. Now I will discuss how disparities have been measured in Healthy People over the past few decades. Next slide, please. To start, here's the definition for health disparities that has been adopted for Healthy People 2030. A health disparity is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on factors such as their race, ethnicity, religion, socioeconomic status, gender or sex, age, mental health, cognitive, sensory, or physical disability, sexual orientation, gender identity, geographic location, or other characteristics. Next slide, please. Health disparities were first addressed by HHS in a formal way with the publication in 1985 of what has now come to be known as the Heckler Report, after then HHS Secretary Margaret Heckler. This report analyzed and synthesized the knowledge related to 6 causes of death that accounted for more than 80% of mortality among ethnic and racial minorities. These findings serve to mobilize some of the disparities-related work and infrastructure still present in HHS today, including the introduction of the Healthy People 2000 overarching goal to reduce health disparities when it was launched in 1990. To achieve this, Healthy People 2000 included over 200 special population sub-objectives designed to reduce disparities in specific populations at higher risk than the total population for death, disease, or disability. Targets for these sub-objectives were set, requiring a greater percent change than that for the overall objective. For Healthy People 2000, health disparities were defined as the gap between these special populations and the total population. For Healthy People 2010 and subsequent decades, the Healthy People 2000 goal of reducing health disparities was expanded to address eliminating disparities and achieving health equity. The definition of health disparities also evolved during these decades to focus on differences linked to social, economic, and/or environmental disadvantage. In addition, the measurement of health disparities gradually expanded to include a broad range of population groups, no longer just limited to selected high-risk groups, and an increasing variety of measures that provide different perspectives to assess progress toward eliminating disparities between population groups. We'll discuss this evolution in more detail on the next slide. Next slide, please. Here's a table showing how disparities measurement in healthy people has evolved over the decades. I'll now summarize some of the key takeaways by row. The first row is the overarching goal related to disparities, which I highlighted on the previous slide. The second row highlights the fact that the approach to addressing disparities in healthy people has evolved as it relates to the setting of disparities targets in the initiative. As I mentioned on the previous slide, in Healthy People 2000, some objective targets were set which were directly related to disparities, but no separate disparities targets were developed in subsequent decades. For Healthy People 2020, we considered progress in meeting overall objective targets and the goal to eliminate health disparities to be parallel analyses and efforts, which both fall under Healthy People. Similarly, while the methods that will be used in Healthy People 2030 to evaluate disparities are still under development, no separate disparities targets for populations will be set this decade. In the third row, the population groups assessed have expanded over the decades. Healthy People 2000 only looked at selected high-risk populations, like selected racial ethnic minority groups. In Healthy People 2010, a standard template with up to 6 population characteristics, these were sex, race and ethnicity, educational attainment, family income, disability status, and geographic location, was used to evaluate disparities whenever data were available by those characteristics. In Healthy People 2020, these same 6 population characteristics were used for disparities-related publications that decade from NCHS, but were then expanded to the full population template for the 2020 online tool at the department's Healthy People website. Healthy People 2030 has a new expanded standard template for which disparities will be assessed when data are available. In the last row in this table, there has also been an evolution in expanding the scope of disparities measurement, which is aligned with the idea supported in the literature that measurement of disparities is complex and a single measure is not sufficient to provide a full context of disparities. We have also evolved our thinking regarding the reference point, a concept I'll explain shortly, from the total population to the group with the most favorable or best rate. The measures shown in bold on this slide are ones that I will cover in the slides that follow. I'll note that for the purpose of this presentation, including this chart, the word rate is used to refer more generally to all measures used in healthy people, including proportions, percentages, and viral rates. Finally, as I mentioned, you can see that Healthy People 2030 methods are currently under development and the subject of the next webinar in this series. And these methods will build on the methods I'm presenting today, mostly from Healthy People 2020. Next slide, please. This slide lists several disparities-related concepts and terms that are critical to understanding how we approach the measurement of health disparities in healthy people. Note that these measurement concepts apply across demographic groups, including those cited on the definitions slide I mentioned earlier. The concepts I will discuss are the reference point, absolute versus relative disparities, pairwise versus summary measures, and changes in disparity over time. The importance of the conceptual framing is further detailed in other resources I will share later, but for purposes of this presentation, I'll just say briefly that each decision regarding methodological choices and their implications was considered thoughtfully for each decade, which is certainly important because of the conceptual complexity of disparities measurement and because each decision directly affects the analysis and findings. And these decisions, taken as a whole for each decade, can be thought of as a way to operationalize the overarching goal related to disparities each decade. Finally, I'll note that multiple measures have been selected for Healthy People disparities analyses, starting with Healthy People 2020. As no single measure is considered the gold standard in the measurement of health disparities, it is useful to evaluate and compare multiple measures when time and resources allow, particularly because different measures can yield different conclusions. Next slide, please. The first concept I'll describe is the reference point, which can be thought of as a specific rate that all groups are compared to when measuring disparities. This selection is important because the choice determines the size and the direction of the disparity. Shown here are some possible options for selecting the appropriate reference rate. The rate for the group with the most favorable rate has been used as the reference rate for measuring disparities since Healthy People 2010. This decision reflects a potential for improvement among comparison groups that is theoretically achievable by all groups. Next slide, please. Measurement of disparities can be done in absolute or relative terms. An absolute disparity, sometimes called a rate difference or an absolute difference, is just a simple difference between two rates. These are expressed in the units used to measure the indicator, for example, percentage points or rates per 100,000 population, and may be easier to visualize than relative disparities. The maximal rate difference is the difference between the highest and lowest group rates for a given data year. On the other hand, a relative disparity is calculated on a relative scale by computing a ratio or percent difference between rates, for example. Unlike absolute measures, relative measures are unit-free, so they can be used to compare measures based on different units, such as percentages and rate ratios. The maximal rate ratio is the ratio between the highest and lowest group rates within a certain characteristic, such as race and ethnicity. And this concept was introduced in Healthy People 2020. Next slide, please. Pairwise or between group disparities compare rates between two groups. And for Healthy People, we have chosen to use a measure of relative disparity, the rate ratio, as a primary measure of pairwise disparities. For Healthy People 2020, the rate ratio is constructed so that the measure is always greater than 1. So it is the higher group rate divided by the lower group rate, regardless of the desired direction of the Healthy People objective. Next slide, please. The summary rate ratio is a summary, also referred to as overall or a cross-group measure, which quantifies disparities across multiple groups using a single number. This measure is a relative disparity constructed using 2 or more rates and really assesses the average disparity among subcategories of a population characteristic, such as race and ethnicity. This measure was introduced in Healthy People 2020, and a related measure, the index of disparity, was used in Healthy People 2010. When there are 3 or more groups and the most favorable rate is the highest rate, the summary rate ratio is calculated as the most favorable group rate divided by the average of the rates for all other groups. Conversely, when there are 3 or more groups and the most favorable rate is the lowest rate, the summary rate ratio is calculated as the average of the rates for the other groups divided by the most favorable group rate. When there are only 2 groups, the summary rate ratio reduces to the maximal rate ratio, again, the ratio between the highest and lowest rate. Note that the maximal rate difference and maximal rate ratio, which I introduced earlier, are also summary or overall disparity measures since they consider all rates in their construction. However, after the rates have been sorted from lowest to highest, their calculation, unlike the summary rate ratio, only use the 2 extreme rates. Next slide, please. So far, I've only described measures of health disparities for a single point in time, but all 3 summary or overall measures can then be used to assess how disparities have changed over time for a given population characteristic, like race and ethnicity, for a specific indicator. For Healthy People 2020, we assess changes over time in disparities for the 3 measures that I've mentioned, the maximal rate difference, maximal rate ratio, and summary rate ratio. But note that changes over time can be quantified based on the absolute difference or relative change, for example, percent change between 2 time points for any measure, for any health disparity measure. All 3 measures of summary or overall disparity shown here are also outlined in Statistical Note 27, which is a publication that provides a seminal reference for measuring progress and disparities for Healthy People 2020. More details about how changes in disparities were assessed for the Healthy People 2020 final review, along with some other findings, will be provided later in this presentation. Next slide. Now we will move to show some examples of how disparities measurement has changed over the decades, focusing on the analysis and data display in healthy people. It should be noted that the disparities methods have changed substantially each decade. The results should not be compared across decades. Next slide, please. The Healthy People 2000 final review included changes in disparity over time. Disparity was assessed by comparing the ratio of the percent change for the group of interest with the total population. For this final review, disparities were assessed for the following populations: American Indian Alaska Native, Asian or Pacific Islander, Black or African American, Hispanic or Latino, women, adolescents and young adults, older adults, and people with disabilities. You can see here the assessment of disparity for the Asian and Pacific Islander population. There were 16 objectives included in this assessment, with 75% of them having an eliminated or narrowed disparity over time. It should be noted that for the Healthy People 2000 final review, statistical significance or percent improvement was not taken into consideration, and a little or no detectable change category did not exist for this decade. So again, we strongly recommend that these results not be compared with disparities assessments for subsequent decades. Next slide, please. For the Healthy People 2010 final review, health disparities were measured using the most favorable or least adverse group rate as the reference point. Note that the designation of the group with the most favorable rate among the groups associated with a particular characteristic does not imply that no further improvement is called for. Health disparities by race and ethnicity, as shown here, were measured using the rate for the racial and ethnic population with the most favorable rate as the reference point. Health disparities are measured in relative terms as the percent difference between the rate for each population group and the most favorable group rate for each characteristic. Next slide, please. Changes in disparities over time were measured by subtracting the percent difference between the group of interest and the best group rate at the baseline from the percent difference between the group of interest and the best group rate at the final data point. As a result, changes in disparities are expressed in absolute terms using the same unit of measure as for the indicator, for example, percentage points or rate per 100,000 population. When there are more than two groups associated with a characteristic, a summary index is used to describe the average percent difference from the best group in the population overall. The summary index provides a basis for conclusions about changes in the average size of disparities associated with these characteristics. This figure shows the number and percentage of objectives with a change in the summary index from the baseline to the final time points by population characteristic. As you can see by the wide yellow bars, which show objectives that had little or no change in disparities over the decade, the great majority of objectives showed little or no change in disparities for each of the 6 characteristics. A detailed description of the methods used to measure and evaluate disparities is provided in the Healthy People 2010 Final Review Technical Appendix. Next slide, please. For the Healthy People 2010 Final Review, disparities were also measured by focus area and at the objective level across 6 population groups. Again, race and ethnicity, sex, educational attainment, family income, geographic location, and disability status. Disparities were calculated from the most favorable group rate for each characteristic at the final data point, and changes in disparity were calculated from the baseline to the final data point. Note that the 2010 analysis was restricted to cases where the same population group composition or specific groups available for analysis was available at both time points, both the baseline and the final time point. In addition, the best group rate needed to be the same at both time points. Changes in disparities are assessed both for the pairwise and the summary disparity. On this slide, we have an extract from a disparities table for a particular objective, 1.1, which was persons with health insurance. In these tables, the group with the best rate is marked with a capital B. The shading of the boxes indicates the magnitude of the percent difference from the best group rate, with darker boxes for groups having greater disparities from the best group rate at the final data point. Arrows show increases and decreases in disparities over time, with increases shown with arrows pointing up and decreases shown with arrows pointing down. The number of arrows in each box is used to denote the magnitude of the change in disparities, with more arrows for disparities of greater magnitude. In this particular example, there's a capital B in the white box, which means that the white non-Hispanic group was the race ethnicity group with the most favorable or best rate at the final data point, 2008. Compared to this group, the American Indian or Alaska Native group had a 100% or more difference, 100% or more percent difference in 2008, as shown by the dark red shading. Finally, two arrows pointing downward in that box signify that there was a 50 to 99 percentage point decrease in disparities from 1997 to 2008. Next slide, please. We will now go into more detail about the methods and tools available for measuring health disparities for the Healthy People 2020 final review. The overview of health disparities component of the 2020 final review directly addresses the Healthy People overarching goal to eliminate health disparities. This product includes an interactive chart and table showing how overall disparities have changed over time using the Healthy People 2020 tracking period for the trackable objectives with population-based data. The disparities analysis included the same 6 population characteristics used in 2010. For objectives included in the analysis, changes in disparities were categorized as either decreasing, increasing, or showing little or no detectable change based on a baseline and final data point for the summary rate ratio. A detailed technical notes publication with information about how these calculations were conducted is available for download on the Healthy People 2020 Final Review website, as I'll show in a few slides. Next slide, please. This slide provides a high-level overview of the methods and calculations used for the overview of health disparities. For more detail, we invite you to reference Healthy People Statistical Note 27, which is the technical 2020 disparities reference I mentioned earlier, and also the technical notes documentation for this particular product on the Healthy People 2020 Final Review website as more information as well. But briefly, changes in disparities were assessed using the summary rate ratio and not using pairwise differences between groups as was done in 2010. Although a reduction in the summary rate ratio generally indicates a reduction in the pairwise differences between groups. Note that for population characteristics with only 2 subgroups, this calculation reduces mathematically to the maximal rate ratio, as described previously. The absolute difference in these ratios between the 2 time points was then calculated, and statistical significance was evaluated if standard errors were available. The disparities change was categorized as increasing, decreasing, or showing little or no detectable change based on the statistical significance or the magnitude of the change using a 0.1 cutoff for objectives without standard errors. Next slide, please. This slide shows the data chart aggregated over all objectives and topic areas included in the overview of health disparities product. These data can be filtered by individual topic area and population characteristic using the interactive menus. For all 6 population characteristics, the vast majority of objectives in the analysis showed little or no detectable change in disparities during the Healthy People 2020 tracking period, ranging from about 80% to 94%. Next slide, please. The overview of health disparities online tool is also accompanied by 2 objective-specific data files available for download on the Final Review website. The first file, referred to as the Change in Disparities Summary file, includes rate ratios and standard errors at the baseline and final data points for each objective in the analysis, as well as the disparity change calculations and final disparities change category. The second file, referred to as the population level data file, includes all of the original estimates and standard errors for individual population groups that were used to calculate the rate ratios and summary metrics in the change in disparities summary. The objective level data in files can be used to answer more specific questions, such as which individual objectives showed the largest or smallest changes in disparities for a particular characteristic. The original data can also be used for additional analyses of interest, such as more detailed pairwise comparisons between specific population subgroups. Next slide, please. The following two slides will present examples of the objective-specific data that are available in the downloadable files. Note that this information is also available on the Healthy People 2020 data website, which has now been archived. Shown here is an example of objective-specific data for HIV mortality using data from NCHS's National Vital Statistics System mortality, indicating that progress has been made in decreasing the overall disparity by race and ethnicity. Specifically, at the beginning of the Healthy People 2020 tracking period, the summary rate ratio for race and ethnicity was 13.9. The summary rate ratio was 7.9 at the final data year in the tracking period, which represents a 43% decrease in the racial ethnic disparity as measured by the summary rate ratio for HIV mortality over time. At both the baseline and final data points, the Asian Pacific Islander population had the lowest or most favorable rate of HIV mortality relative to other racial ethnic groups. Next slide, please. Shown here is an example of an objective overdose deaths from the use of synthetic opioids, excluding methadone, also using data from the National Vital Statistics System mortality that showed a notable increase in disparities by sex over the Healthy People 2020 tracking period. At the beginning of the decade, the rates for males and females were similar. However, by the end of the tracking period, rates had increased in both groups, but at a higher rate for males than for females, resulting in an increase in the maximal rate ratio of 136% from 1.1 to 2.6. Next slide, please. Shifting gears a little, I wanted to briefly highlight the Healthy People 2020 Disparities tool, including several key concepts I've explained on the previous slides. Unlike the final review product I just showed, which includes only data describing the change in disparities between the baseline and final data points for the 6 population characteristics, the Healthy People 2020 Disparities tool provides data for all applicable years and population characteristics included in Healthy People 2020. Shown here is an example of how the data appear in the Disparities tool for objective MISH 1.3, infant mortality. The most favorable group or reference group and least favorable group are always shown in blue and red, respectively, regardless of the desired direction. More detailed summary data can be accessed by year, and explanatory footnotes can be found beneath the chart. Note that we have closed out data tracking for Healthy People 2020, and this site is now archived. This version, the archived version of the content, is still available, but may appear differently than the screenshots shown here. And one more slide, please. All right. These screenshots show how the data appear when selecting a summary of the data for a particular year. In addition to the bar graph showing the data estimates for individual population subgroups, the disparity measures calculations that were previously discussed in this presentation are provided as shown in the screenshot on the right. Specifically, the display shows pairwise rate ratios for each group compared with the best group rate, which in this example is the Asian or Pacific Islander group. In addition, the maximal rate difference, maximal rate ratio, and summary rate ratio are all provided in the bullet points on the far right. Next slide, please. The final Healthy People 2020 related disparities product that I would like to describe is an NCHS report that was just released today, titled Examining Progress Toward Elimination of Racial and Ethnic Health Disparities for the Healthy People 2020 Objectives, using 3 measures of overall disparity. As I mentioned, for the Healthy People 2020 final review, we assess changes in disparities over time for a subset of Healthy People 2020 trackable objectives using the summary rate ratio. The aim of this Series 2 report was to expand the suite of disparities measures in the assessment of changes over time to include the maximal rate ratio and maximal rate difference, in addition to the summary rate ratio. This Series 2 report specifically focuses on changes in disparities by race and ethnicity for the same objectives included in the final review disparities product. The figures shown here provide a high-level overview of some of the results in the publication, focusing on the disparities change categories and how they compare across measures. Figure 1 on the left shows that most objectives in the analysis showed little or no detectable change in disparities over time, regardless of the measure. But this percentage was highest for the summary rate ratio, which again considered the most favorable group rate compared to the average of the other group rates, instead of just considering the highest and lowest rates. In addition, the percentage of objectives that narrowed or decreased was higher than the percentage that widened or increased across all three measures. And you can see this with the light blue bars being slightly wider than the red bars in figure 1. Another aim of this report was to evaluate how consistent the disparities change categories assigned to individual objectives were across the three measures. Figure 2 on the right shows that for about 75% of objectives, they were classified in the same disparities change categories for the three measures: the summary rate ratio, the maximal rate ratio, and the maximal rate difference. The highest pairwise agreement in classifying the disparities change category across all three measures was the summary rate ratio and the maximal rate ratio. These findings further support the results from the Healthy People 2010 and 2020 final reviews, that health disparities have generally changed very little over the past two Healthy People decades, and that multiple measures of health disparities can offer different perspectives for assessing progress toward their elimination. Next slide, please. Finally, I wanted to highlight this figure from the same report, which examines objectives that show the overlap in the objectives with the 10 largest widening or narrowing for the three measures, an analysis done to evaluate consistency in the findings. While a majority of the objectives that showed the largest widening or narrowing were specific to one of the three measures, and these objectives are not shown in this figure, several overlapped across two or more measures. This figure shows the 14 objectives that did show an overlap, with those in black font showing a consistent widening or increase, and those in red showing a consistent narrowing or decrease. Of note, the objectives related to hepatitis C infections, IID26, and occurrence of spina bifida, MISH 28.1, were among the top 10 objectives showing the largest widening in disparities across all three measures. Two additional objectives related to HIV mortality, HIV-12, and hepatitis A cases, IID23, were among the top 10 objectives showing the largest narrowing in disparities across all three measures. In addition, there was one objective, reduced drug overdose deaths involving synthetic opioids, excluding methadone, MPS 2.4.4. And this objective overlapped across all three measures, but the direction of the change was not consistent. This inconsistency reinforces the notion that different conclusions regarding changes in disparities can sometimes be reached depending on the measure used. Next slide, please. Now it's time to leave you with some key takeaways and a look ahead. Next slide, please. Healthy People has had a major focus on health disparities and health equity over the decades. And although the methodology has somewhat changed from one iteration of Healthy People to the next, we have continued to try and provide insights into changes in disparities over a broad range of population subgroups and objectives each decade. Specifically, here are some key takeaways. Measurement of disparities among population subgroups is complex and multidimensional. Therefore, multiple measures, a suite of measures, if you will, provide different approaches for assessing progress toward their elimination. And that is the approach we have taken for Healthy People, starting in Healthy People 2020. Although I only had time to briefly touch on the measures today, I'll note that consideration should be given to the inherent characteristics of these measures in selecting which measures to use for analysis. Health disparities tracked through the Healthy People initiative have generally changed very little over the decades, with most objectives showing little or no change over time across the population characteristics examined in our analyses. Next slide, please. Looking ahead for Healthy People 2030, we have a variety of interactive tools, infographics, and products planned for the decade, working with our federal partners, including ODPHP. We are currently working on a Healthy People 2030 Disparities tool in collaboration with the HHS Office of Minority Health and ODPHP, building on the Healthy People 2020 version of the tool illustrated today. Also in the pipeline are subnational data and maps, building on such work included in Healthy People 2020. Next. Specifically for Healthy People 2030, we are currently refining the methods that will be used for the assessment of disparities this decade. Similar to the Disparities tool for Healthy People 2020, the 2030 tool will be accessible on the Healthy People website and will build on the features available last decade. For example, the Healthy People 2030 tool will include multiple disparities measures and also a new feature that will eventually show an evaluation of changes in disparities over time at the pairwise and summary levels. In addition, the population groups available in the tool will show additional population group categories beyond those used in Healthy People 2010 and 2020 to reflect the expanded Healthy People 2030 population templates, although not all objectives will have data available for all population groups. Further information about the Healthy People 2030 Disparities tool will be shared in the near future. Next slide, please. The next two slides will cover several disparities-related resources that expand further on the material presented today. This slide includes a few disparities-related websites. First, there is the Healthy People 2020 Disparities tool, which has been archived, and the Healthy People 2020 Final Review Overview of Health Disparities. There's also a great online tool produced by the National Cancer Institute, the Health Disparities Calculator, which the branch closely reviewed in the development of methods and tools, starting in Healthy People 2020. Also shown on this slide are some general Healthy People websites that may be of interest. Next slide, please. There are also several manuscripts that may be of interest, and I'll just touch on a couple of them. The first one, an NCHS statistical note that outlines methods for measuring progress toward target attainment and elimination of health disparities for Healthy People 2020, is one that I mentioned a few times today. This is also known as Statistical Note 27. And building on this publication, the branch does plan to release a similar publication to document progress and disparities methods for Healthy People 2030. And again, the disparities methods will be the theme of the second webinar in this series in 2023. The second manuscript listed here looks at progress toward eliminating disparities among racial ethnic populations over the 2020 tracking period using the three measures discussed earlier. And this manuscript was just released today, as I mentioned earlier. Next slide, please. I would like to acknowledge the following current and former DAE staff for their contributions to this presentation. Without their support, this webinar would not have been possible. Thank you very much for your time and attention, and I look forward to your questions.
We are now entering the question and answer session. As time allows, the presenter will address questions from the Q&A box. Please submit your questions through this feature now. If your question or comment is not addressed, please direct it to paoquery@cdc.gov. That email is on the screen now. I see we have lots of questions flowing in already. Thank you, David, for a wonderful presentation. All right. So I will start off with a question for you, David. At this point, the Healthy People 2030 Methods and Disparities tool has not yet been released, and they're the topic for the next webinar in this series, which you mentioned will be sometime next year. Can you tell us now about how Healthy People 2030 disparities methods and content will build on what we've already seen in Healthy People 2020?
Sure, I'd be happy to do that. The Healthy People 2030 initiative, as I mentioned, has expanded on the full population template that's used in Healthy People 2020. And again, the 2030 disparities tool will include multiple disparities measures and also a new feature that will eventually show an evaluation of changes in disparities over time at both the pairwise and summary levels. And part of what we're looking to do is not just to show the data, but also to show data visualizations that will help users better understand what's going on. And again, you do really need to kind of turn into the next part in this webinar series to hear more about that, as at that point, we will have the first version of our tool, as well as the publication outlining our methods for the current decade, 2030. So lots to look forward to in the future.
Absolutely, and we'll be sure to publish that webinar that's coming up in the same ways that we did this one so that you all can sign up and join next year. So our next question is, will AAPI categories be broken down to separate Asian from the NHPI where possible moving forward? When did this in kidney disease? When we did this in kidney disease, it unmasked substantial disparities for the NHPI community.
Yes, that is actually part of our standard template for Healthy People 2030 to have the Asian and Native Hawaiian other Pacific Islander group broken out separately. So as long as the data source collects information with those two populations in separate categories, we will show them whenever those data meet the applicable presentation criteria. That's definitely a priority of ours, and certainly we know that that is in line, for example, with the standard 1997 OMB categories for reporting data on race and ethnicity.
Great, thank you. Our next question is, will future Healthy People products, such as the 2030 mid-course review and the 2030 final review, now be online web-based products?
Yes, so that is something that is a marked change in Healthy People 2020. We went from very static kind of PDF files that did not allow for a lot of flexibility to, at the end of the decade, having a dynamic web-based product for the final review. So that is certainly part of our plan moving forward, and we recognize that having a web-based product gives us more flexibility to take advantage of the rich data that are in the Healthy People initiative and to be able to create more relevant interactive tools and charts. And our hope is that these characteristics will and features will enable our users to better understand the data that's most relevant to their work. So that is definitely the direction that we're looking at moving forward.
Great. Also kind of looking forward, at which point in the decade can you start assessing disparities over time?
So while this changes in disparity can theoretically be assessed at any point once you have a second data point, in the past we have waited until at least the midpoint of the decade to assess changes in disparities for Healthy People, since it may be difficult to kind of detect changes over time with a shorter tracking period. For this decade, we are working through some methodological issues before we include the changes in disparities over time in our forthcoming disparities tool. But certainly users who wish to calculate changes in disparities over time for Healthy People objectives or for other measures could certainly do so at any point once there is a second data point. Again, with that caveat that with fewer data points, it is a little bit more difficult to detect changes over time.
That makes sense. Thank you, David. This is a question that we get very frequently at NCHS overall, but let's answer specifically to this Healthy People disparities data that we're talking about today. Are the measures that you've been presenting on today at the national level, or do you also follow up? Do you have state level or small area level measures as well, so that we could kind of zoom in on these disparities at a local level?
So the data and the measures that I presented today were data at a national level. Certainly the analyses, the methods that I presented could be extended to looking at data on a subnational level. We just don't have the time and resources to necessarily do that for the Healthy People Initiative with my group, the Health Promotion Statistics Branch. But certainly we do encourage others to consider our methods, consider other methods that are available to do their own analyses, extending them to different levels of geography.
Great. And kind of keeping with that line of state and local level data and coordination with your Healthy People team, how are these tools cascaded and communicated down to the states and to their departments of health? It seems preventing duplication and sharing resources would allow for larger benchmarking and data standardization.
Sure, and that is a question that we get a lot. So I definitely appreciate the interest in kind of cascading the measures and the tools down. So we work very closely with ODPHP, our partner in the department who kind of manages and oversees the Healthy People Initiative, to kind of connect us with various partners. We have gotten some inquiries from certainly folks working, for example, at the county level on our methods and tools. And so, part of what I mentioned as far as providing technical assistance, that's something that we do very readily whenever we get those types of requests. We do encourage, again, folks to use our tools and methods as much as we can. And I think looking ahead, we are kind of looking for ways to kind of distribute and disseminate not just the methods, but maybe even the tools. I touched a little bit about target setting, and for this decade, we actually developed some Excel tools that are now available on our website so that folks doing target setting at other levels can actually use the same tools that we use on a national level for setting targets in their own work. So something that we have definitely discussed moving forward is if there are disparities tools that we could also filter down and disseminate through the publication of something like that. That's certainly a very real possibility. That's probably a little bit further down the line. But again, the methodology, the tools that we have available on our website now, we're really aiming to be comprehensive and to be fully transparent in what we're doing so that they can be replicated at various levels. Certainly, we welcome any sorts of suggestions or any specific feedback or input that you all might have, and really thank you for your interest in this work.
Absolutely, and we are getting just overwhelming interest in our Q&A feature, so it doesn't seem like we're going to have quite time to get through everyone's questions, but we will keep chugging along until we reach our time limit. So our next question is, how does the way Healthy People categorizes the various demographic characteristics for health disparities compare to other federal agencies, such as departments of education, housing, transportation, etc., as well as the census categorizations?
Sure. So a lot of our categories that are found in our population template are categories that are specified by the Office of Management and Budget, or OMB. And that is the government agency that kind of sets standards for all federal statistical agencies. I didn't go into this in detail, but some of you may know that NCHS is the primary federal statistical agency for the Department of Health and Human Services. And as such, we do follow guidance put out by OMB for federal statistical agencies for collection and reporting of data. Certainly, there are parallel or equivalent agencies found in other parts of the federal government. So, for example, the census is the federal statistical agency for the Department of Commerce, and they would follow the same guidance that comes from OMB. Now, certainly, we recognize that there are data collection efforts that don't necessarily fall under OMB, and so that's kind of where it becomes a little bit trickier to align and harmonize the data templates. But I think data standardization and kind of trying to get to the same categories is an important kind of issue, agency and maybe even across public health efforts to try to kind of move towards more standardization. I think this is an important question and issue to kind of continue to keep tracking, but it really just kind of depends, what the oversight is for the particular data collection and agency. And again, there are movements, I think, to kind of move towards standardization. We're not quite there yet. And I also recognize that data standards are changing. So OMB is certainly considering, for example, whether changes should be made to the racial ethnic standard that I mentioned earlier, which were last revised in 1997. So all that to say, there's a lot of kind of work and interest in data standardization, and we're doing our best to kind of use the data that are available and to be able to provide it in a standardized way so that comparisons can be made across a variety of objectives. And that certainly is a challenge with about 80 different data sources that are currently used in Healthy People 2030.
Absolutely. Well, I am sad to say we've reached our time today. I know there's so much interest in this topic, and we have additional questions still coming in. I'm gonna play bias and do this one last question. I know we're gonna go a little over time, but since I'm a policy folk, I see it coming in. Can you give an example of how different disparities measures can yield different results, and how might this information be used by policymakers?
Sure. So just really briefly, that was actually one of the examples that I highlighted in my talk today, as well as an example that is in the new Series 2 report that just came out today, number 195. And we found that there's actually a great example in there where using two of the measures, the maximal rate ratio and summary rate ratio, the disparity in race ethnicity for the objective on drug overdose deaths, decreased, but then looking at the third measure, the maximal rate difference, there was actually an increase in disparity, which I know can be confusing. But that example really just kind of underscores the importance of considering both relative and absolute measures to get a full or fuller context of disparities, because again, you can get different conclusions based on the different measures, and there is not necessarily always a straightforward policy recommendation. Certainly, I would point you to other organizations that kind of deal more with policy. So a couple of examples: the Kaiser Family Foundation, the Robert Wood Johnson Foundation, do have some really good resources to provide some insights on kind of the relationship between health disparities and health policy. So again, as a federal statistical agency, we at NCHS put out the data, and we rely on others, the subject matter experts, people working in policy, to kind of provide more of the policy insights and recommendations. But hopefully some of those resources and my comments regarding this were helpful.
Definitely super helpful. I've learned a lot today from you, David. Thank you so much for your expertise and for your presentation and for your whole team's support of that presentation. Unfortunately, that is all the time we have for today. Thank you for your attendance and questions in today's webinar. A recording of this webinar, along with the presenter's slides, will be posted on the NCHS website in the coming weeks. Have a wonderful afternoon.